Hello, everyone, and welcome to this year's Dutch Design Week, Designing for Health Journeys panel. We hope you're having a very inspiring Dutch Design Week so far, but of course we hope to trigger some extra inspiration during today's talk. My name is Iris Boyakkers. I am a service designer based in the Netherlands, and we also have Vedi Sapatka here, who's calling in from the US and works there as a design researcher. Both of us work at Philips Experience Design, and together we will kickstart today this interactive discussion with our esteemed presenters of today.
Today's talk is centered around reimagining the behavioral health experience. And you'll be hearing from Alex Stan, the design director, and Colleen Newland, senior experience lead at Philips Experience Design. They both have worked across many spectacular award-winning and healthcare innovation projects and come with a rich breadth and depth of knowledge when it comes to designing for healthcare. By diving into their project, we also get to know a little bit about them and their practice. Just to give some context around the project, many adolescents seeking mental health care end up in their local emergency department. As a last resort, they experience psychiatric boarding. Held for days or weeks in an empty room worsens their conditions. We'll be exploring and getting to know more about how Alex and Colleen's award-winning project helped improve the experience of young mental health patients by creating an immersive, adaptive, and safe environment that helps improve care delivery. Alex and Colleen, the floor is yours.
All right. Thank you very much, Vedahi. So thanks everyone for joining this talk. So as Vedahi and Iris said, we're going to be presenting this collaboration project that we had with Children's Health in Dallas to really try and humanize this patient experience for families going through this mental behavioral health crisis, actually. And before jumping into it, I'd just like to give some very quick kind of statistics and just to explain the context behind this problem. There has been, as we all know, coming out of COVID, there's rise in kind of a mental health crisis, actually, where children and young adults are experiencing a lot of mental health issues. There hasn't been a lot of, let's say, effort or funding in finding treatment for these kids. And as a result, the area of the last resort that they go to is their local emergency department, actually. And frequently, these emergency departments are not geared up to handle these the influx of these kids coming seeking for help, right? And as as we see, what ends up is that they just kind of basically board the children and just place them in a room and basically hold them there and not really kind of treat them right until to let them calm down and before they release them back into community. So this kind of vicious cycles continues. In this picture, you see is basically a typical room, right? There are no windows, basically no furniture, everything is kind of locked up, and the children basically spend hours, days, sometimes weeks in this environment, and you can imagine what it does already to your fragile mental state status, actually. And these rooms are kind of designed to be safe for the children, or that's what they want to, so they don't hurt themselves, they don't hurt others. They don't have furniture, they cannot basically hang themselves in this room. So these are kind of almost like prison cells, actually. And when Dallas Children's came to us, there was already a big issue with this. All their patients are coming in. There's an increase of traffic, which also takes away from the services that they can deliver to other patients, needing emergency care, actually. So they end up occupying these rooms for many days, and that takes away from the other kids as well that's seeking help. So the journey started when Dallas Children's came to visit one of our experience labs. So this is our NICU experience lab. And they kind of saw that some of these technologies that were in our future thinking could maybe be applied to their emergency department. So they pleaded with us to say, hey, look, can we do a kind of investigation into this a new environment? And that's something that actually from a design and business point of view, Philips was not involved in this kind of behavioral health area. So it was definitely a kind of leap of faith and a journey that we went into this unknown to, you know, explore this possible solution to help these children. So I'm going to briefly play a short video, and then we can pick up the discussion later on.
During these challenging times, a mental health epidemic has afflicted our youth. Dramatic increases in pediatric anxiety, depression, and suicidal ideation, coupled with a lack of support services, are pushing many families to turn to hospital emergency departments as a last resort.
Having to take care of these kids that are here for 2-3 days or maybe even 2 weeks or beyond, that was never a role that the ED was designed to fulfill.
Philips is collaborating with Children's Medical Center Dallas and Reconnect to create a next-generation behavioral healthcare experience in the emergency department.
Philips is a wonderful partner with us. There's no one else that is reaching into the walls of the hospital to say, what can we do today to make life better for children?
The multidisciplinary team observed existing units and conducted interviews with staff, family, and patients to spark inspiration and align with existing clinical operations. Research was synthesized into a set of themes that support de-escalation and therapy for a wide range of pediatric patient types.
We learned from staff that this ultra-tunable environment is really key. So some children need as little stimulation as possible, and others need a much more engaging environment.
To bring the themes to life, the team created an adaptive exam room environment comprised of tunable lights, calming sounds, and interactive play elements. The ambient experience elements seek to calm agitated children in order to lessen risk of injury and need for sedation, which tend to increase length of stay.
I think the unique thing is that the kids can personalize their space according to different themes that are geared towards their age group. This gives them a sense of comfort and control.
Immersive projections with subtle details can be used by staff during therapeutic treatments.
I think that will be a really helpful tool in helping calm a patient if that's what they need at the time, or helping de-escalate in a way that's positive and non-intrusive.
A Reconnect impact-resistant touchscreen enables kids to access entertainment, select themes, and build trust with staff through interactive games. The system can be managed to gradually provide access to new features as patients make progress throughout their stay. Ongoing study will enable the team to learn from the pilot and continue to improve the solution. Grounded in meaningful, human-centered innovation, the adaptive exam environment seeks to make life better for patients, families, and clinicians, and help get kids back to living life to the fullest.
Thank you, Alex, for sharing this project, and Colleen. We have a couple of questions, and also for the audience, you can put any questions that you have for Alex and Colleen in the Q&A. What I was wondering, as designers, one of our jobs is to empathize with end users and stakeholders. And I can imagine for this particular patient group and environment, there may have been some sensitivities involved there. So a question to you, Colleen, how did you navigate the sensitivities around this environment, and how were you able, as a designer, to empathize with this particular patient group and the other stakeholders involved?
Yeah, thank you, Iris, and thank you again for the opportunity to share this project. Yeah, it's a really restricted, sensitive environment, and I think we knew that going in. You can't just walk around and talk to people, and certainly people that are in a heightened mental state. I think that it came down to two things, really. I mean, Dallas Children's Health, they were willing and able to give us access to people, patients, families, staff. They really did everything they could to remove barriers for us, and they wanted to hear the voices of their staff, patients, and families. So they really helped us with that. And then secondly, I think just the brave and committed parents and families and patients that were willing to talk to us with the goal of improving the experience. So we talked to 3 major groups: patients, parents, and staff. And I think maybe just looking at the patients themselves, we did have the opportunity to speak with a former patient, a teenager who had had a long stay. You can imagine it's a very vulnerable thing to do, to come and talk to designers about that experience. But that really kind of opened up some things for us as understanding their preferences. For example, the teenager that we talked to, he really shared that one of the biggest things he would have liked to see was, being able to have more movement and physical exercise in the room. We'd been thinking about this very calming, still environment, and he kind of unlocked some things about new opportunities for the space. Parents, they're also having the worst days of their life probably coming into the space. They told us that they were, exhausted. They're coming to the ED as a last resort. So they've been trying to manage the situation at home maybe, and so they can't take a breath or rest until their child calms down. So this is also a space for them. They're often staying with their patients or with their children, in the same room. And then finally, staff. So the amazing staff, there's all kinds of people involved. And in the graphic you see there, we're really trying to map who's involved where, between child life and social workers and ED nurses and security officers and psychiatrists, a whole slew of people involved in patient care and triage in this moment in the ED. And I think one role that really stood out to us that I think we really empathized with, and kind of, you almost have to take a moment to explain it because it's so critical to understanding the context here, is this role of a sitter. And the sitter is, in a behavioral health ED environment, someone that's assigned to provide continuous visual observation of a patient. So you're sitting at arm's length for a shift of 8 or more hours, staring at a patient, making sure that they don't harm themselves or others. That is an insanely tedious job. You're getting patient aggression, patients wondering why you're staring at them, you're intruding in someone's space, and yet you're also trying to keep the, mental capacity up yourself to watch this patient. So there's a huge burnout aspect there, and understanding this journey, understanding all of the people and players involved, all due to the hospital making this available to us, really helped us kind of clarify those needs across the journey, I'd say.
Sharing, Colleen, it's interesting to know how kind of hospital helped you connect with patients, staffs, and parents. You don't see that kind of collaboration often with clients. So it's interesting to know, just to kind of poke more on the patient piece while designing for young adults seeking mental care. How did you ensure the solution was kind of inclusive and accessible across the different patient use cases?
Yeah, that's I love that question because it really was the challenge, right? It's how do you make an environment work for a huge age range? You're talking ages 6, sometimes even younger, believe it or not, up to 18 for mental health care in the environment. All kinds of mental states presenting, and you have to do that in a way that's safe. I think pediatrics environments, it's a challenge no matter what with the age ranges. Traditionally there's that fixed decal on the wall. We've all been there as teenagers in the room with balloons, and you're thinking, wow, I'm so out of place here. I think that's also what the Children's Health is experiencing too. We have these very static rooms, and I've got an 8-year-old and an 18-year-old, and it's not working maybe for either. So our goal was really to create an environment that worked, that could be adaptive and tunable to suit that huge range of patient needs and preferences, kind of at the flip of a switch. So I think we have a slide that kind of pulls up these different patient types, but we have, I think this project really introduced me to this idea of designing for neurodiversity and just the different ways that brains function and process information. And the staff really helped us understand this. It kind of broke down their patient types. Your suicidal patient may need a lot more expressive environment that helps them communicate. So sound and music and the ability to draw, for example. Your patient that has autism spectrum disorder might need a very like low stimuli room, turning everything off, making it very tactile, like more hands-on type games. An aggressive patient may need a very like calming space, and you may need to introduce some of these coping exercises. So it's an enormous range of, take that on top of all the different ages. And I think this is really where we wanted to kind of push the ambient experience, Philip's ambient experience to the extremes, and really let these patients kind of like DJ their own experience as much as possible, and bring back that sense of autonomy so that you can have that 8-year-old in the room that then an 18-year-old can enter later and have just as good an experience.
Thanks. That must have been quite a design challenge indeed, can imagine. And we already talked a little bit about sensitivities, and building further on that, considering this patient group, I can imagine a hospital doesn't just give you access to this environment and let you research and prototype around. So Alex, could you elaborate a little bit on how you were able to establish this trust with the hospital partner that allowed you to do this project?
Yeah, I think, the trust that actually we wanted to establish, was that we were able to, go in there and listen to them and actually understand their needs, right? And what Colleen shared in, part of, what she showed with the patient, different patient age groups, and the whole journey map that we did really helped prove to the hospital that we actually understood, their processes, what are their challenges. And also, I think bringing in our kind of design thinking hat, where we actually included all the stakeholders, right? That wasn't something that they really kind of consciously thought about. And we were able to almost, go in there. We actually went in there for, a couple of days and actually, followed the staff, understood, what they're saying, and interviewed, like Colin said, even ex-patients, the sitters, and observed them, and be able to come up with a framework that kind of made sense to them and kind of pointed the way to, hey, look, these are where some of the key bottlenecks or issues are. So with that kind of, I think, our design skills, I think we quickly proved to the hospital that, hey, look, this is something that, we know what we're doing, and we actually understood their problems and their challenges, and we were there to be able to help, right? So I think that was definitely one of the first steps into building the trust, actually. I think the other part, where I think designer kind of starts coming together, is that we'll be able to also quickly translate some of these problems and needs into solutions, into visuals, into tangible ideas that they could relate to. And, one of the things that Colleen mentioned was that at one stage, the hospitals, they were kind of arguing amongst themselves, what kind of mural should we paint on the ceiling, right? It should it be an octopus, or should it be the whale, and it wasn't, so we showed them a different kind of way of looking at things. So, hey, look, by introducing some more advanced technologies, we could maybe make this room more adaptive, and in order to suit the kind of different age groups, actually, and different types of patients that come into this room. And by the way, these rooms are also actually designed to be, even if you're not behavioral health patients, it will still deliver benefits because you could be there as well. So it's really, truly inclusive, not just for behavioral health rooms. So I think that kind of created this kind of trust. But actually, one of the key moments that, of course, we created a lot of designs and images to help, bring the idea across to the hospital. But one thing that we did was to, once we kind of knew the idea of what we're kind of talking about, we actually went down to Dallas and actually created a mock-up, a live mock-up. So Colleen and I were there. We converted actually a meeting room into actually a projections kind of space. So to just show them what could there be the impact of this, right? We brought in part of a solution and just kind of mocked it up in a very rough way, and invited the executives to actually tour the room. And people were actually very, kind of blown away by this whole thing, that they could suddenly see something come alive and tangible and experience it. So I think that's, again, another part of, our designer skills, to make things tangible and to allow people to experience it. When you tell some people something versus showing them something, I think it's very different. And I think I can still remember the CEO of the hospital coming in, touring this, and saying this, hey, this is a no-brainer. Why are we not doing this, right? So that really kind of sealed that kind of concept, in the sense that, hey, look, this is definitely something that's a very viable. Yeah, so and during that time as well, this kind of making it testing a hypothesis, as we call it. We also receive a lot of ideas. So when people coming in to enrich this whole concept actually, and yeah, in terms of how we could develop some of these projections to be more therapeutic. So when people saw it, the nurses and the psychologists and folks like this, they could actually bring it further than what we could. So it's really a truly collaborative project to do. And again, that's kind of built on the trust actually that we both have.
Wow, this is all fascinating, how certain tools and processes like design thinking, custom frameworks, you facilitated research. Trust building is always hard and a slow process. So by kind of co-creating with them, it makes the solution truly patient-centric. Some of the questions we have from the audience, there are a lot of questions. People are really enjoying the session, but one question that particularly stands out is from Tessa, and she asks, how did you manage to do so much work with children and hospital care professionals with all the regulations and sensitivity involved? And how is the collaboration with the hospital in this way? And either of you could kind of take it up.
I could take it up with you once. I think one of the things that we find, working with Children's Hospital is that the staff members, the hospitals, they're very passionate. Actually, I've worked with Children's Hospital for many years, and I think that's the one thing, is that they're always very passionate about their patient population, and they actually always go the extra mile actually to do something more than what a regular hospital would do, right? Because these children are the most vulnerable, right? They're and yeah, I would say one of the things is to and we always have a good relationship, because we kind of try to spend a lot of time to understand these hospitals and their population. So we build up this kind of good relationship. And of course, there's a lot of sensitivity, and sometimes there's instances where we wish we could talk more to some of these children, but of course there is definitely this whole privacy issue, which is very important, in which we respect a lot, and so we don't always get to talk to these children, but when we get time, and I think, and when their parents also kind of, I think sometimes also how do I say that, they are actually grateful that, hey, look, someone is coming in here to try and help, right? So they do open up themselves as well as their child, and volunteer, things. Hey, look, so we find opportunities where we can. It's not easy to navigate, I would say. There's definitely lots of laws and regulations there that we have to look at it. But I just find that the whole group of in this pediatric space is generally very open to this kind of collaboration, because actually I would say they're kind of underserved by a lot of businesses and let's say communities. So anyone that comes in, they're actually open to collaborate. Hope that answers that question.
Thanks for sharing, Alex. Yeah, it's interesting that not only we have to deal in this environment with the sensitivities, but also with these regulations that the healthcare industry poses, like these privacy concerns and other healthcare regulations. Mm-hmm. We actually have another question. Oh, go ahead, Alex.
Well, maybe just to follow up. Yeah, and I think these regulations, right? We have to also prove this, the effectiveness of this solution, which we just can't go in there and just kind of claim, hey, this is going to do X, Y, Z and cure everything, right? So I think these regulations are there for a good reason. And with this solution in Dallas as well, when at the moment trying to collect a lot of evidence to say, hey, look, this is actually an effective solution, and early evidence is showing that it is turning out to be good, and we can talk about that a bit more later.
Yeah, I think we're actually getting a question coming in that's related to this evidence, and maybe Galeen, you can answer this. After the solution was constructed, what was one of your favorite stories about the use of the space or the solution as a whole?
Oh, yeah. I mean, I think we did go back. So Alex and I went back to do a post-occupancy evaluation about 3 months after the pilot went live. And we learned a lot. And that's when you really see, how the space is being utilized. And the story that really stood out to me, I don't know if Alex can feel the same way, but the story that stood out to me is the story that I like to refer to as the basking in the red story from a staff member. Because we were asking staff, how are the rooms working for you? What have you been seeing? What have you been observing? How has it impacted your work? And a staff member, a nurse, was telling us how they had a very aggressive patient, destroying furniture, destroying walls, throwing furniture at the walls, being verbally abusive towards staff. And they ended up moving this patient into one of these pilot rooms, which they refer to as the Phillips rooms. And this patient, who had essentially been on a sort of rampage, went over to the touchscreen, and the staff described as the patient went over to the touchscreen and he selected this red light color. There's cove lighting in the room, and when you select it, and if it's on full intensity, it's like full on red light, like you're really basking in the red kind of thing. He didn't have any other projection or sound on just this red light, and sat there on the bed basking in the red. And the nurse was telling us how other staff member kind of like saw this red glow coming from the room, and they'd come down to be like, what's going on in there? Should we stop this? And the nurse was like, no, like this is working. Like the patient is calm now. And I think that story stands out to me just as a designer. I think it had come up, Alex, when we were going through the design process of, should we have red even as an option for patients? That's a very aggressive color. It might be kind of agitating, those kinds of things. It did come up of like whether or not it should be included. And so it was really interesting to hear the story of, and as the staff described it to us, they felt that this patient was sort of communicating aggression and anger through the light, right? Not having to do it physically or verbally. It could use the room to communicate a mood. So that was a kind of aha moment for me of the space, thinking about this environment not as a way just to change a mood, but as a way to express a mood if you're a patient. So I thought that was really interesting. And you could say it like challenges our design biases about color, but probably the bigger lesson there is just like go back and talk to people and see how they're really using the space, and like, yeah, the red light's getting used. So I find that really fascinating.
Yeah, and I think I think one of the lessons there as well for us is that we cannot anticipate, or we can try and design everything up front, but going back and learning about it, and you find that a lot of people maybe end up using our designs in a very different way, or interpreting it in a very different way that we cannot anticipate up front. And I think this was clearly one of the ways that that manifested itself. So again, I think it's a good lesson for us as well.
Yeah, I think it's fascinating how kind of myths around color that a lot of times we hold were kind of debunked. It's super interesting to know. We have another question from the audience. Folks want to know kind of like, what are the key takeaways that you got from this project? And Alex, if you want to take that up.
Yeah, key takeaways. I think there was definitely, quite a few key takeaways. I think one we just mentioned, right? It's hard to anticipate all the end outcomes, and going back and doing this kind of post-implementations research study is actually a really great thing. And in fact, what we did, which actually is really good, is to put a QR code in the room that allows real-time feedback actually from the patients and the parents and things like this. And again, hospitals, the Children's Dallas was gracious enough to allow us to do that. So we're actually getting real-time feedback in terms of, hey, look how this has been enjoyed, and what's working, what's not. So that helps us continuously improve. Actually, and that's something I think we cannot do more of. Actually, we should do more of these. Actually, so I think that's definitely one of the big things. I think another key takeaway is that when we come together and collaborate in this area, I think it's also just creates a completely new line of thinking, and also a new business opportunity. As I think as Phillips, right, those thinking more from the business side. This was something that was not in our scope, so this whole behavioral health area before our collaboration with Children's Health of Dallas. But now, we've kind of seen that, hey, look, this is the pilot has been successful, and there's actually quite a lot of demand in the market in this area. We're starting now to look at, hey, look, this is something that is actually being commercialized as a new business. So this opened the whole idea of this customer-led innovation was another way of how innovation can come true, right? So it's not always saying just in-house you do your research and develop, but you go out there and really co-create that. And Colleen, please jump in if you kind of also think about anything. There's a couple of more I think that I want to talk about, but I think Colleen, I also want to give you an opportunity to jump in.
I mean, I can just add one to build off that. Just the testing and learning mindset, and like designing with this population and not for them. I think can be so much stigma and like fear around this type of space, or even this type of patient population, that like nobody wants to touch it, kind of thing. It's too restrictive. There's so many rules, understanding it. And I think what was so great about Children's Health Dallas is they were willing to test with us. They were willing to kind of go on this journey together. And Alex, you talked about this at the beginning, like we all had this shared testing mindset. They didn't know what was going to work. We didn't know what was going to work. We agreed we'd figure it out together. And so I think just going in together and being willing to be brave enough to explore, the hospital being willing to create new content, create new themes with us, and just try it and see, and create their own proof points, and be willing to pioneer in that way, I think was really instrumental.
Yeah, and I think another kind of learning point, building off this is that one of the unexpected things that we pulled together was this a partnership with a third-party company to provide this indestructible touchscreen, right? So that was again something that was not in our Philips portfolio, and I think through partnership, I think that's a way for us to also accelerate quickly, rather than say, hey, look, we're going to build this by ourselves. So it's taken us years, right, to do this, and this project actually turned around very quickly. So we actually knew that, hey, look, this is a lacking part of our capability. We were lucky enough to find this partner that had this super amazing touchscreen that we could then integrate our system and deliver as part of that solution, actually. So again, I think partnership was also actually something that we sometimes have to think, hey, do we have to just build everything yourself? And increasingly in this complex healthcare ecosystem, one company cannot do everything by ourselves, right? And we need these kind of partnerships. And the story around this touchscreen, I think we also had an unexpected kind of result, was that Colleen earlier talked about this, a sitter that sat there and stared at the patient and had nothing to do. It became an avenue for them to bond and communicate with the patient. It allowed so I think in the picture here that's showing is that the staff members, the clinicians were actually able to let's say even play games, simple games with the kids, right, or do some drawing and therapy sessions. So this it became a kind of tool that enable communications and bonding and interaction between let's say the children and the staff members, which is again something that just emerged out.
Yeah, Alex, maybe just on that note, the story that sticks with me with the staff member talking about that, he says it's so much easier to say, hey, you want to play a game of checkers, to a kid than to just stare at them. You're not going to get a kid to talk to you just by staring at them. So having this kind of as an icebreaker or something to do, and to give that sitter, it totally kind of changes the dynamic between that relationship. It was really interesting to learn. That is not something we anticipated at the beginning.
Interesting. And there's some questions coming in around this topic. So we discussed a little bit those the staff engaging with this room and the patients, but there's also, of course, these parents that are around or sometimes visit. You already touched a little bit on that, but can you explain a little bit further on how did you see parents typically engage with the patient and with this room?
Yeah, I can speak to that a little bit. I think, yeah, you might think of patients as being kind of an overlooked user of the room in any behavioral health environment. So parents are typically joining their patients, accompanying their children into these spaces, and are often, if it's safe, they will stay with them in these tiny, again, 10 by 10 typical standard rooms. So, you know, you're pulling up a cot type of thing or pulling in a chair for a parent to sit in. I think, yeah, while the parent wasn't the core focus of our design, I think what we found was parents were so, and what we're hearing in some of the feedback from that QR code survey is they're just so relieved not to just have a TV on the wall blaring. They're looking for calm, they're looking for peace. As I said, that they can calm down when their child has calmed down. They can feel at ease when their child is at ease. They can sleep when their child is sleeping. And you have very exhausted parents in these situations that are kind of caught in the middle and or don't know where to go, essentially. And you're, again, not knowing how long you're going to be in this situation. So they're trying to get info from the staff and communicate that back to their child. You're kind of in a helpless state. So it brings a sense of autonomy, I think, back to the parents as well, in that sense. Anything you'd want to add to that, Alex?
No, I think you're right. Actually, you know, this just gives that parents a break, right, and know that their children are looked after, and and I think especially what we're finding or what we're hoping this room will achieve is that the hospitals do not need to use sedation or restraint, right, on these children through this, and their evidence. That's what one of our main goals is. For parents to see that your child needs to be restrained on the bed, I think that's the most painful thing, right, that you can kind of experience, and so I think that's really what Colleen said, right, when you calm down the child, it actually also helps with the parents and also the staff members, right, the stress as well, if you have a screaming child trying to deal with this. So we find that this actually has a lot of impact beyond just the immediate family. It impacts the staff members, such as the security team and things like this. One of our main goals is really to reduce this use of restraint, use of medication, and also the kind of the idea of escalation, right? Reduce the number of violent incidents and escalations.
It's nice to hear how you kind of navigated those sensitivities. Just to kind of change the course of our discussion a bit, we have a question from the audience. They want to know if you can share some of the other concepts that you developed and the ones that were not pursued, and like what were the main reasons for choosing like one concept over the other, as we heard that y'all were prototyping, very hands-on and kind of testing things out.
Should I take this one? I guess I'll take this. Yeah, I think, I've just pulled up a slide, so I think when we went into this journey, right, one of the things was that, hey, we want to do something within that timeline that's achievable, right? So I think that's one of the goals. And when we went in and did the whole, let's say, research of discovery and concept ideation, of course, we came up with lots of concepts. And here you can see maybe a kind of a spectrum of actually end-to-end kind of journey that the team with us were very excited to kind of look into and create, right? So we had many different things that talk about how you're presenting information as you're coming from triage and even beyond as you left the hospital. Could you create a lasting experience or something to take away that can help even the child as they left the hospital to go home? So think about certain apps or certain things that can coach them continuously. I think one of the things that we yeah, we decided to do was just to narrow down the focus, because we wanted this pilot to be successful and to be able to get something very tangible very quickly, so we can make an impact on proving that, hey, this can go forward, right? So rather than trying to look at everything, we've said, hey, this is a narrow focus, and that allows us to create impact and get evidence. And then I'm hoping that eventually we can go even further and look at the other areas, because this is definitely a very big territory. So this is definitely one of the first steps. There's definitely many ideas we had that's still to be implemented, and maybe Colleen can talk a bit more about it. I think even
Yeah,
like
I
the
think
content and things.
I think yeah, we had lots of ideas around content, right? And the sky's the limit there in terms of things that you can do and create, and in terms of content. Other technology pieces that are maybe just more on the horizon, being able to incorporate telehealth into the space, even exploring the use of camera-based monitoring, circadian lighting, I think was one that came up a lot. So the room is prepped for it, but it hasn't yet been programmed, right? So some of these things, to Alex's point, we really had to focus down to get the room built and get the pilot launched, but we haven't lost sight of them. I think there's even like some people have asked us about interactive projection and some of the, like full immersion projection mapping on the room and some of those more advanced audiovisual technologies. And we were really trying to work with kind of, let's say, more off the shelf parts and keep it really kind of lean in this first sense. We didn't quite know if interactive projection might be a step too far, right? You might have people punching through the walls and you've created an even worse situation potentially. So those were all things that kind of came up and we thought, okay, yeah, it's maybe a little bit too far right now. Let's keep our focus on what can be achieved and tested in the short term, and then we can grow from there.
So obviously, you had a lot of ideas, some more futuristic than others. And there's a question from the audience more on the process of how you actually got to those ideas. So could you explain a little bit more on the co-design activities or the design techniques that you used and how the children in the hospital professionals responded to them?
I'm thinking, Alex, of some of the content that we were creating with the staff there. I feel like that was a moment where we had some pre-existing themes that we were using, and children's health, and together with us, we really thought it would be interesting to co-create some new themes. And this is where I think they really provided us with amazing insight and sort of bringing in and embedding techniques that they use in their daily work to calm patients and to teach them some coping mechanisms. So it's something that they could even, a skill, that they could take home with them after discharge, kind of learning a paced breathing, how to kind of release a thought and let a thought go. So we had a couple of nature, more bright green nature theme and the Starry Night theme that you see here that we designed hand in hand with the staff there. And I felt like that was a really tangible way where they saw our progress, they provided us feedback, they had a lot of these ideas basically that you see there in the content and really help bring those things to life. So I think that was one of the clearest examples of co-creation where yeah, they could bring their expertise into the solution itself.
Yeah, and I think they definitely had a lot more ideas that at this first stage that we could not implement. But I think those are definitely in our backlog right now, right? So how can you even make that kind of more interactive or real-time tracking the vitals of the child and seeing and then making a projection respond to that, right? And either to help them energize them or to calm them down, these kinds of things. So that's definitely a lot of this kind of discussions there. And I think also maybe one thing not to forget during the process, we have this kind of of course very rich co-creation, discovery, and talking to the staff members. But I think also after the fact, when we went back to visit, there were definitely things that we that we both did not know that were just kind of bugs or trouble issues that we just had to kind of look at, hey, fixing and changing, because those this was a very quick pilot project. We want to get it out there to prove it, but of course there are still things to be optimized. So maybe I think one of the things was the positioning of this touchscreen that was outside the room, right, Colleen, that, they were saying that they could not really, that the position was kind of wrong, because if they had to go outside to use that touchscreen as a master control of the room, they could not really see the child in the room. So that kind of didn't give them that kind of, so that line of sight thing, we had to definitely improve a bit more. And I think also the position of that touchscreen was just kind of at a level where it could just, a car could just come by and just, crash into it and break it off the wall. So, things like this that we kind of knew, but, I think it was good that, this was again, confirmed. And yeah, we had to just kind of also look at, beyond this initial part, how do we co-create and keep improving our solutions and our results, actually.
Yeah, because in many ways, right, like launching the pilot is the easy part. I mean, it wasn't easy, but in the grand scheme of things, that's the easy part, because then it's the follow-up and the follow-through, and okay, what do we learn from this? How do we evolve it? How do we keep improving it? How do we make it better for the next customer and take it forward?
Thank you for that. We're also getting some more technical healthcare questions. So we have a question coming in from Nina. If there's any other monitoring tools apart from the feedback from hospital staff where you collect data from future improvements. So as an example, she mentions heart rate reduction in these rooms, for example, or are there other Philips capabilities that are available in these rooms to get that feedback and to improve over time?
I mean, I can speak certainly to the main way that we've been receiving feedback and data, let's say, is from the QR code survey that's available for staff, patients, and family. The hospital themselves, they are conducting their own research of these rooms, where they are going to basically kind of see how we can measure outcomes. What are their levels of sedation and restraint? What level of aggressive incidents have they seen in these spaces? Yeah, exactly, Alex. Length of stay. Have we been able to reduce length of stay because we've been able to calm a patient down sooner? So while we don't have necessarily like vital tracking, I don't believe, on the patients in these spaces, I think the way that the hospital is really thinking about proof points is in these outcome metrics, which will take time to measure. But this is currently underway, and we really established these up front. I think at the very beginning of the project, we were kind of going through this list with the customer to understand, like, what does success look like for you? What metrics are really important for you for this to really have an impact? Like, what would your goal be? And this was our top list of clinical outcomes, in addition to improving the patient and staff and family experience. So this was kind of our driving beacon, I'd say, throughout the whole project. So we needed to be able to come back and measure these, and we thought about that at the very beginning of how we were going to do that through the hospital data.
And I think maybe also, I think the question is also about how do we monitor, the room and also the patients in terms of their vital signs as well. And that was actually, I think Colleen mentioned one of our futuristic concepts that we proposed, which was to use basically a camera to be able to monitor the state of the patients, right? Because with these patients, you don't be strapping, sensors and patches on them. So we actually have a piece of technology, that can actually monitor a patient from a distance using just the image, right? So a camera feed that you can look at their vitals, their heart rate, their breathing rate, etc. But yeah, unfortunately, that has, when it comes to putting cameras in rooms and looking at patients, there's a lot of definitely regulatory and privacy hurdles. So that's something that, we hope that in the future that we can still be used, but I think that it just take a longer time to get past the regulatory hurdles. But it's definitely something that we're aware of, to see whether, in terms of also safety, right, the patient, are they about to get into an aggressive, agitated state, or escalations might happen because their heart rate is rising, things like that. So
yeah.
Just kind of building off, you mentioned the role of technology. Would love to kind of also know like how you define the role of technology in the context you were working with, Alex. Does it kind of replace or enable or go hand in hand with the human component?
Yeah, I think one of the things that we see is that the technologies, it should not replace that human connection, right? And we try to make it so that it is something that is still, it encourages and facilitates human interaction and human, bonding and connection, right? Because we can easily say, hey, look, let's just strap on the VR, goggles to this child and that's it. But then they're isolated and they're cut off from this environment, right? And that's why I think, we were very conscious in terms of when we designed this room that just to still maintain that human relationship, that clinical staff and patient relationship, that is not cutting them off, or so there is there's some examples of what we're looking at is to let the room, the visuals, the adaptivity help express human their emotions, or help augment them. So yeah, it's definitely more of a facilitator, I see, of relationships and interactions rather than a replacement.
Yeah, I might just add to that, the staff described it as sort of like the sooner you can get a patient calm and to talk, like the sooner you get to a diagnosis and the sooner you can get things moving in the system to prevent these very long, prolonged escalated stays and falling into that vicious cycle trap. So any way that the technology can support that communication and getting a patient to feel comfortable expressing themselves, whether that be verbally or on the, on the touch screen or through their choices that they're making in their environment, that goes a long way towards the staff being able to move patients through the system quicker.
All right. Thank you both for being generous with us and sharing your project journey with such rich and insightful session. We'd love to go on and know more, but unfortunately, we're nearing the end. I'd love to ask this last question to you, Colleen, sort of in retrospect, what would have you done differently if given a chance to change one aspect in the project?
Change one aspect. I mean, I feel like I have a very obvious answer, but it has occurred to me in hindsight of what is it really like to spend 24 plus hours in a windowless room? So maybe as a designer, experiencing that prolonged stay in both a kind of the standard, let's call it prison cell room, and a room with our solution in it, and actually feel what that is like in the hospital environment. I don't even know how this would be possible, but it's the combination of being in that room and feeling isolated, but the no sense of time, night or day, because you don't have windows, the noise from the surrounding patients who are also struggling and maybe extremely loud around you, staff coming in and out, not knowing how long you're going to be there, that kind of uncertainty aspect of where's the horizon here, I think you would come away with some insights, I think, that we could even further adapt and improve the design just from a designer's perspective, uncovering new ways to think about it. I don't know, Alex, anything you would change?
No, I think your answer is really good. I think you're already experiencing that, Colleen, in your basement.
Right.
So I think you have gone through that.
Getting there, yeah.
Great. Then maybe a very short one, because this is almost the same one. I will ask this to you then, Alex, so you can round off. Maybe things that not about things that you would have done differently, but things or there are lessons learned about something that has gone wrong, if any.
Things that have gone wrong. Yeah, I think definitely, in this whole journey, it wasn't, a smooth journey, right? Many things, we had a tight timeline and time deadlines and getting things together And of course, I think things that gone wrong. One thing that came up to mind is that, during the go live kind of week, of course, our system was down. It had a lot of bugs and things like this because we're integrating for the first time with this new, third-party software. And when you have so many, folks, the IT department of the hospital, our technology and third party coming together, it took time to kind of troubleshoot actually and get things right. So, sometimes the projection or the touchscreen will stop working and someone had to come and reset it. So we definitely had a lot of teething problems. But then again, we went into this as a pilot, right? So I think that was good that we set that expectation that, look, we are just exploring this journey together, and we were given the space and the leeway by both the hospitals and the team actually, who helped us to gave us that opportunity and time to really troubleshoot. But yeah, those are some of the things that I think we kind of went wrong in the going back at implementation. That I was just like, we would like a smooth implementation, but at the end now it's like running smoothly and up live. So we're grateful for the team that helped to make that happen.
Yeah, thanks for sharing that. And all of those things that go wrong, that's what the design process is like, right? That's how we learn and iterate. So we're entering the end of this talk today. So Colleen and Alex, I think you've provided us a very complete view of the solution that you created, also on how you created the solution. So thanks for sharing these learnings and these interesting anecdotes with us today. There's a lot more questions coming in. Unfortunately, we don't have time to answer them all, but luckily we do have some other opportunities later this week to come and learn from our Philips designers. So if you want to learn more about the projects that we do in Philips Experience Design, there are 2 more talks this week that you can join. So we have one tomorrow at Wednesday morning, and also a final one on Thursday afternoon that you can join. So I invite everyone to come and listen to those projects as well. And then if you're in Eindhoven this week, then of course you are very welcome to join us at the Philips Design Museum. We have an exhibition standing there, and the Philips Design Museum in the city center of Eindhoven, and you can visit that the entire week to learn more about what we do and how we exactly do that. So thanks a lot, everyone, for joining us today, for your engagement in the Q&A, and enjoy the rest of your Dutch Design Week.